Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is HIV TB co-infections in children. We shall be discussing the case studies. The speaker today is Dr. Kalpana Datta. Dr. Kalpana Datta ma'am is the program director with the Pediatric Center of Excellence in HIV Care, professor and head of Department of Pediatrics, and in charge of Adolescent Clinic at the Medical College, Kolkata. She is also a national trainer for malnutrition, pediatric HIV, early child development, and NTP program. She has published many papers in international and national journals. We welcome you, ma'am, for today's session and request you to start the session. Ma'am, you're on mute.
Okay, now it's
Ma'am, you'll have to share it again.
oh, I didn't say. But there is no questions. Pre-test questions are not
Yeah,
there.
we'll run it from our end, ma'am.
Okay, then it's okay.
Yeah.
Okay, now it's okay.
Yes, ma'am. Thank you.
Okay.
Requesting
So
Kiran, sir. Yeah. You can go
we'll
ahead,
be
ma'am.
talking on the HIV TB and the case-based studies and some note when to suspect tuberculosis in pediatric patients and what is the difference with the adult and how you proceed for the diagnosis. So before that, the main session will have some code. So I think
Thank you,
pre-test code
ma'am.
will be there. Will be
Yes,
step
ma'am.
by step.
Kiran, sir, can we have the pre-test, please? Thank you. The pre-test questions are now visible on your screen. All the participants are requested to scroll through all the 4 questions and answer them.
But it's not visible in my screen.
Ma'am, maybe because you're a co-host. At times it happens, but it is
Okay.
visible to the participants.
Okay.
Yes. I'll read out the questions. Which of the following statements is not correct? TPT should be given to PLHIV and CLHIV with more than 12 months who is not having active TB. Second, HIV exposed infants less than 12 months in contact with active TB. TPT reduces the overall risk for TB by 60 to 90% among PLHIV. TPT should not be given to a pregnant woman, and TPT should be given to all individuals with previous TB treatment. You have to say which sentence is incorrect among the 5 options. The second question is which is not true. Breastfeeding can be given if mother is under treatment DSTB. Breastfeeding cannot be given if mother is under treatment of DRTB. ATT excreted in small amount in the milk has no therapeutic or adverse effect on the baby. All children born to mothers with TB should not receive BCG at birth, even if they are on isoniazid preventive therapy. Third question, which is not correct in 4S screening in children? Current cough, fever, poor weight gain, or poor appetite? Last question, which statement is true? TB occurs in less than 6 months of initiation of ART. It is a failure of treatment. ART should be administered with rifampicin containing regimens.
I have
If
that was ionized continuity, not if I change it.
okay, sorry, ma'am. Okay. If TB develops more than 6 months of initiation of ART, the decision of ART failure should be based on CD4 count and viral load data. The PTB after 6 months of ART without other clinical and immunological evidence of disease progression should be regarded as ART failure. We'll give 1 more minute for the pretest, requesting all the participants to please attempt the pretest poll. We'll discuss these questions after the post-test also at the end of the session, requesting all participants to answer the pretest for now. You can scroll through the questions and answer them. Only 8 participants have answered till now.
Oh, others also not getting the pre-test question in our ART center.
Must be a internet issue, ma'am, because participants are answering the pre-test.
Oh, if it's in the running of the slides now, I would have been seeing
Right,
that.
right, right. Suparna, ma'am.
She's in the ART center. She went to ART center.
Okay. Kiran sir, we can end the e-poll.
Okay, doctor, hi, internet issue. She has come. Do you want to say something to Suparna?
No, I'll call her later, ma'am.
Okay.
Yeah, thank you.
So should I start now?
Yes, ma'am. Yes, please.
Okay. So my today's topic is an HIV and uh, co-infection as a tuberculosis in children. So what is the motto of this session are understanding the dynamics of HIV TB co-infection in children. So what happens if the HIV is there and super adaptive infection is there? What happened to HIV virus? What will be the tuberculosis bacilli? What how they will act synergistically or opposite? These things to be discussed. Know that you have to know the TB screening protocol to be followed in ART center. Learn the device diagnostic algorithm for TB in child living with HIV. Learn the approach of different types of tuberculosis, any other organs, because tuberculosis is a disease which is a multi-system disorder. It can involve any organ, and but the age is different because, like in kidney, is usually in a very adult. In the reproductive tract, that is also an adult female and all. So we'll talk about which is common in pediatric age group. Prescribe the daily antitubercular treatment regime according to the latest NTP guideline, that is National Tuberculosis Elimination Program guideline. Learn the ART regimen to be prescribed on what are the treatment modification in ART when the child is having both HIV and TB. New aspiration, what is the NTAP things? No global move is towards the TB elimination. Then, of course, after that, it will be eradication, but we have to achieve the elimination by 2025. The diagnosis TB needs to be more different, like it is now microbiologically based. So each and every cases of tuberculosis, it is a try to establish microbiologically by hooks and loops. So we have to prove it by microbiological testing. If not possible, then we'll go for the clinical. Rapid detection is there because of the we have a nucleic acid amplification test and the recent improvement in the investigations. So we can see also the INH resistance, mono resistance also. Rapid molecular tests make it easier and better as compared to the first. So TB control activities in the world and in the children is started and tried to. It is a promise to eliminate by 2025. For that, we have to know the burden and the problems, the hurdles, what we are facing as a pediatrician or the dealing with the pediatric. 2018 witnesses 10 million new cases. So 2008 there's a 10 million new cases, out of which 8.6 were people living with HIV, and more than in the African countries. And among which 11% were children out of 10 million. Estimated 1.6 million deaths were there. 1.2 million were there, though HIV negative means about 0.4 million are from the HIV positive. Additional 251,000 deaths from TB among HIV positives. So globally, 57%, so more than half cases were among men, then in the children, and the male-female ratio was close to 1, and two-third burden in 8 countries. So among the 8 countries, India is the topping the list. This is 27%, and the lowest one, the South Africa, that is 3%. Now in the highlight will go for or highlight no for pointer, which one I click.
Ma'am, there's no feature of pointer
Yeah, I
currently.
can
If
see.
you can
Okay, then
just,
I can do the arrow.
yeah, do it with
Can
the
you see
cursor.
my arrow,
Yes,
the
yes. You
cursor?
can see the cursor,
Oh,
ma'am. Yes.
okay. So global estimated TB incidence, which is in the black line, this is the black line outer cover, and case notification disaggregated by age and sex. Female are in the red, it is depicted in a red color, and male in darkish blue color. And if you see the distribution, we are interested up to 15 years. You just consulted the last two because it's in total up to adult also. So 0 to 5 years, you will see this much from the outer, the whole rectangle covered with the black marks should have been diagnosed cases. But we are diagnosing only this, only red portion is the female child and the male child. So you see the how much gap is there. So they are having tuberculosis, but they are not picked up. And if you go up a bit low, so going above downward, you see the gap is quite high. We are missing many of cases of tuberculosis, whether with HIV or without HIV. So the region-wise estimates is there, and the not diagnosed. If you see in all the countries, not only in India, as we are not able to diagnose, but in all the countries, there are some gaps in more in Africa than India, but there are some gaps of the detection. The case detection gap is the percentage of TB patients are missed in a different age groups. The TB reporting is the biggest among the young. You see that 70%, near the 70% gap was there. So this should be total length should have been detected cases of tuberculosis below 5 years, but out of which only 31% were able to diagnose, the rest was missed in the society. So this is the huge challenge against the elimination of tuberculosis in our population. So in India, we see this is this much out of this outer cover is the black cover. Total cases should have been diagnosed, but the small percentage of red and the turquoise blue, with the percentage you're diagnosed, and these are the huge gap detection gap in the under 5. So why so? Why were you having a such a gap? Because there are lots of problems are there. The overlapping symptoms, the chronic pulmonary symptoms due to HIV itself. The HIV can cause the weight loss, can cause anorexia, can cause the respiratory complications, it can cause fever. So all those are mimicking with the tuberculosis. Then again, the other co-infection, like other opportunistic infection in HIV, can mimic with the tuberculosis. So sometimes it is missed, like lymphocytic interstitial pneumonia, bronchiectasis can mimic tuberculosis. Even the simple pneumonia can mimic tuberculosis, because nowadays we are seeing getting the cases of tuberculosis presenting very acutely within 3 to 5 days, fever, chest pain, and cough. And that is usually previously we thought it is only because of the bacterial infection and pneumonia, not because of the tuberculosis. Weight loss and failure to thrive are both features of HIV and TB. As the HIV disease progresses and the individual becomes more immunocompromised, the clinical presentations are again more vague, more vivid, and is more likely to have a extra pulmonary tuberculosis when there is a severe immunocompromise, or there may be a possibacillary. So that gives like the smear negative HIV, even in uninfected or infected TB patients also. So it is a more in the HIV infected patient, and it is also available in an uninfected child also. This can result in a misdiagnosis or delay in diagnosis, and in turn higher morbidity and mortality. Again, in radiology, chest X-ray interpretations. So we miss lots of chest X-ray because of the tuberculosis can mimic many type of diseases. Difficult with the presence of other HIV-related conditions like pneumonia, LIP, bronchiectasis, because in all cases, especially in case of miliary mottling, even LIP can give the miliary mottling the lung, bronchiectasis sometimes can have bronchopneumonia, can have different disease with the tuberculosis. HIV-infected patient with active TB, proven or respiratory culture can have a similar normal G6. Sometimes we do get cases that the gastric lavage and or the sputum was positive, but X-ray there's no radiological finding because we don't go for the CT scan in each every cases. So really we do CT scan, and where it is can be visible, but sometimes we may get the normal G6 with the smear positive tuberculosis. Similarly, in the microbiological test, sputum microscopy has a poor sensitivity in detecting TB, especially in younger age group, because when you collect the sputum, it may be the saliva, and when you do the gastric lavage, then as there is already peristalsis has started, so you won't get any gastric lavage positivity. There are lots of problems are there collecting the gastric lavage and the sputum in pediatric age group. Usually they are possible ciliary, then the bronchus is not communicated with the tissue because we have a lymph node tuberculosis in the lung, pulmonary hilar lymphadenopathy. So we don't get the bacilli in the sputum or then the secretion. So even microscopy may be negative or poor sensitive might be there. NAT, that is a nucleic acid amplification test, the frontline test for diagnosis TB in all the persons, not only among child living with HIV. NAT is not available. The NAT is nowadays it's available, and there are centers in every districts and every places that because by the NTP people. They are supporting us and government of India. So I think it will be available. But there's a programmatic issue. Sometimes we don't get CBNet. The cartridge is finished. This is not available. The Falcon tube is not there, and all that. There may be some issues. At that time, it's difficult to collect the do the test. And transport is also important. By we are transporting, how long you are taking to transport, and if there's sometimes NAT is negative, at that time we can do the MTIT that do in the NTP people, the microbacterial growth indicator tube is more sensitive when NAT is negative, we can do it. So where do we miss children and with the TB, and why do we have such a huge gap in detection? Because of the overlapping symptoms, overlapping signs, and overlapping investigations and results. Often are underdiagnosed, underreported due to lack of simple, sensitive point of care tests like sputum smear of adults. Like if you suspect some child is coughing and all, if it would have been an adult, you would have asked to collect the sputum at the center only. But you can't do the sputum because you have to induce a sputum either giving nebulization with a normal saline, bronchodilator, then normal saline, then induction of a sputum. You have to generate it and then collect it. Or you have to do a gastric lavage. So it is not possible in the point of care test. You have to send it in the indoor facility. It is available. TB control strategy not so well equipped for the diagnosis of TB among children. Not only TB, any cases, first the guideline is formed on the basis of adult, then the adult data is extrapolated, and the pediatric guideline is a framed. This happens in all cases. Similarly, in TB also, program is organized with the adult case in mind. Childhood TB action thus often need to retrofit into the mold already set for the adults. So the setup is there for the adults, and we have to mold it childhood TB in that setup, and so there is some fallacies. Differences in the disease and in diagnosis among adult and children creates a divide. So bacteriology to radiology versus radiology to bacteriology. But nowadays it says bacteriology to radiology first with the bacteriology. But still we are sometimes we're not. It is not possible to go for the radiology first. So risk of HIV TB is very common. Why so? HIV positive children increased risk. As such, HIV negative children is lifetime risk of having a positivity. If the positive test, then it's a 10%, but in HIV cases, it is near about the 60% lifetime risk of acquiring tuberculosis. They are suffering from HIV. TB in a child living with the most severe, it's a more progressive and likely to occur in the extrapulmonary side. So in severe form, usually you get endobronchial tuberculosis, miliary tuberculosis, disseminated tuberculosis, and sometimes it's more common in the extrapulmonary side. Rates and the drug resistance are quite high in tuberculosis, especially when they are having HIV positive. Recurrent disease, relapse is common in HIV infected children. The mortality of the TB is quite high, especially when CD4 count decreases. But minor tuberculosis can happen in any CD4 count because tuberculosis happens in the HIV negative also. So any CD4 count, the CD4 count cannot predict which child is having it can have a tuberculosis, which child won't have a tuberculosis. So what happens when there is a HIV infectivity? So there is a suppression of immune system, and there's a worsening of immune suppression leading to all the immune systems are suppressed, so leading to the decrease in interferon gamma or T helper cell 1 lymphocyte, and that is because this is the protective for the microtubercular infection. As it is decreased, so there will be microtubercular tuberculosis, and it will LTBM means latent tuberculosis was there, that was manifested. So it will be a clinical disease. If it is there's a exposure to tuberculosis, there will be a clinical disease. Then that clinical disease, what will happen because the microtubercular tuberculosis is very much attracted to the macrophages, it will stimulate the macrophages cytokines productions, that is interleukin 1 and TNF alpha, and these IL-1 and TNF alpha helps in the replication of HIV virus. So what will happen? It will give much more viral replication, and that will rapid progression of HIV disease leading to AIDS. So it is in a vicious cycle. Again, as there's a AIDS, there's a decrease, severe immunosuppression, then again further decrease of the interferon that will further propagate the tuberculosis bacilli, that will further down the cytokines, and that will again increase the multiplication. So this goes in a vicious cycle until unless breaks you will give by giving the antituberculous uh, therapy to break the cycle. So TB accelerates the HIV disease progression, higher immune activation, increased HIV replication, and AIDS-defining illness are quite common. And the AIDS pace away by for the clinical tuberculosis, a mycobacterium TB dissemination will be quite high if there is a co-infection. Now, diagnosis with TB infected child. How you do it? It's a symptomatic screening for TB should be routine for all HIV infected children, including HIV diagnosis, comments of ART. Because whenever they come to the ART center, whatever the visit is there, either for the diagnostic point of view or the confirmation, you have to screen for the force symptom. And then if it is diagnosed and you are going to start the ART, you must rule out the tuberculosis in each and every visit. The approach of the diagnosis, both pulmonary and extrapulmonary, is similar in HIV infected child as for the HIV uninfected child. So I'll show a few photographs, and the flow charts is very similar in both the cases. Treatments also similar, but the manifestations sometimes may be varied, maybe severe, maybe progression. Diagnostic challenges are greater because of co-infection with HIV, and that reduces the specificity of the typical and clinical radiological features of the TB. Because the presence of HIV is very difficult, if baby is having fever, whether it is because of the tuberculosis or HIV cases, because you have not started ERT or it is not yet to be suppressed. So it is very confusing. And if there's a lung findings, sometimes we have a gut findings, we have a failure to thrive. It is because the HIV disease or other co-infection or tuberculosis. Very confusing. Moreover, in co-infection, it is a quasi-bacillary. So it's very difficult to get the result for confirmation. Chronic and persistent lung disease is common in HIV infected children because of the other opportunistic infection, as I said. So it is very important each and every cases, which should not be very brief in taking the history. History should be very carefully taken, and detailed history must be taken, the others will miss sometimes. Clinical examination, again, thorough clinical examination, head-to-toe examination, general examination, systemic examination must be done. There's no shortcut, no skipping the things, otherwise you'll miss the cases. Then, of course, there is any secretions, tissues, fluids, if you collect, go for the bacteriological confirmation by the nucleic acid amplification test. And then you can take the help of radiological investigations, whatever the radiological investigations are needed or possible. Investigations side this if you suspect pulmonary tuberculosis, then the investigation will be different. If you think about extrapulmonary tuberculosis, depending on the site, your investigation will vary. So what are the 4S symptoms? The 4S symptoms are if it's an adolescent and adult, then current cough, fever, weight loss, and night sweats. But in case of children below, we say current cough, fever, weight gain, contact with the tuberculosis. Now, current cough. So I'll discuss the flow chart. I'll discuss about the current cough, because cough is very common in pediatrics. If there's a change in viral, there's change in weather, change in season, it is maybe allergic cough, it must be asthmatic cough, it will be viral infection. So in all the cases, you won't go for the TB testing. So the treating physician was sitting in a ART center. He will look at the child, he will see the clinical history and the clinical features, and he will decide whether we have to send you for the tuberculosis or not. Similarly, the fever, and the poor weight gain, again, it may be due to the faulty feeding, it may be due to inadequate feeding. So that things to be taken in consideration while taking the history. And now the contact with the TB cases. So what do you mean by contact? It's very important because we do miss the history of contact. So any child, when it comes in contact with any adult person who is suffering from tuberculosis or has suffered from tuberculosis in the last 2 years. So any history of tuberculosis in the last 2 years, suppose sometimes the parent might say, no, there is no history, family history of tuberculosis in my family. Because if you in further inquire, you might know if they have finished the father had finished the tuberculosis treatment 6 months back. That's why she is considering at present there's no history. But by definition, it is the history of contact is positive. So you have to take the history and detail whether baby has in having the contact. Now, how much contact? Ideally, it should be overnight contact. We said it's the overnight contact for 1 or more days in a closed room. Then we say it is a contact of TB. Now, suppose that the four symptoms you have identified, because it is a two flow chart. One is the less than 12 months is different, and above 12 months is different. So there's two chart. Child with the more than 12 months of age living with HIV first screen for the poorest symptom. So current, again, as I already said, current cough, fever, with history of contact with TB cases, you must justify this. The current cough is unexplained, fever is not explained by. Suppose that the dengue season, everyone is having dengue. There can be a dengue also. So that does not mean it in all cases you have to send it for the tuberculosis. In case of malaria, you can have malaria also. So different disease you cannot ignore while dealing with the HIV patient, because this HIV patient can have a child can have a other disease also. So the treating physician must be aware of all those diseases which are prevalent in that particular geographical area, that moment of time, and that season, or in their family. So all the family members suffering from cough and cold and viral, like few days, a few months back in the February March time in West Bengal, we had many cases of adenoviral infections. Even the HIV positive children have suffered the respiratory infection, and because many cases of it. So similarly, what is going on, you have to take all things in consideration while saying these poor symptoms are positive. Then poor weight gain and contact with the history with the TB. Suppose it is not there, then actually this is the flow chart for actually pulmonary tuberculosis. But sometimes there may be gland swelling. So you have to see the thorough examinations there, because all those symptoms is not there. Sometimes we have seen in our center also, these symptoms are not there, baby is not suffering from TB. No, you have to see any gland, you have to see the child whether there's any lymph nodes or enlarged, and how to approach a case of lymphadenopathy I'll be discussing. So it's very important to know the other things are there, and pain, abdomen, diarrhea, bony swelling, and all. Assess for contraindication. So if there's no history, no cough, we think there's no symptoms suggestive tuberculosis, then you have to give the INH prophylaxis therapy. Then what you have to do, you have to see is there any contraindication. What are the contraindication? It may be hypersensitivity, it may be hepatotoxicity, it may be peripheral neuropathy. So whether there is any contraindications there or not. If there's no contraindications, then you give IPT. If there's a contraindication, then defer for the time being, and according to the contraindication, whether absolute or relative, treat like this. Now, if this history is positive, so what for his symptom is positive, then the what site, type of what site you are suspecting if the tuberculosis is in the lung or in the gut or in the lymph node. And so you have to collect the sample, and you have to do for the microbacterial and the um, NAT test. And then if you need radiology, you take the help of radiology. So it may be either TB or not TB, or it may be other diagnosis. If TB, then treat for the tuberculosis. If not TB, then follow up and consider for IPT. If other diagnosis, give a appropriate diagnosis with IPT. So features of tuberculosis. So what happens in the HIV immunosuppression in the HIV patient in early phase of HIV, whether there's not so much severe immunosuppression, clinical presentation they may mimic in the post-primary tuberculosis, means the cavity formations and all. But in the late phase, it is resembles primary TB, means primary progressive TBs. Because in tuberculosis and pediatrics is quite severe, it may be progressive, it may be bronchial, it may be miliary, it may be disseminated tuberculosis. Again, sputum smear may be positive in the early phase, and the late phase, as I will say, is possibly bacillary, and it may be negative. Chest X-ray again, as there's the early phase, it mimics adult, so it can cavity formation, because cavity formation is the hallmark of adult tuberculosis. And in the late phase, it mimics primary tuberculosis, so different type of progressive primary tuberculosis, the variety of presentation of progressive primary tuberculosis you can get any one of them in the late phase. This slide is not visible, I don't know why. I think it is given, the slides are given the different case X-rays in different CD4 count. Though it is not visible in my slide, I don't know whether it's displayed or not. But I would like to say the CD4 as such does not predict the occurrence or progression of the disease. Though in the serious low CD4 count, it can be progressive primary tuberculosis or disseminated in a severe form. But in the normal CD4, having normal CD4 can have a tuberculosis or any kind. So HIV TB co-infection, 50% of children with HIV disease is atypical, as already said. It may be extrapulmonary malaria. Pulmonary TB, we know, I've already discussed all those things. And extrapulmonary, as I said, depending upon the site, it may be lymph node, CNS, bone, TB of the cerebral efficient pericardial. I'll quickly pass on few pictures. You have a pictorial impression that you can pick up early. And it may be the dissemination. So, this is an HIV infected patient. As I already said, we discussed this much. Pulmonary TB suspected, extrapulmonary TB suspected. Now, if it is pulmonary TB, what will you go for that? We'll collect the sputum anyhow, either direct collection of sputum or induced sputum or gastric lavage. Because baby used to swallow the sputum, they don't have the tacit powers to cough it out. And sometimes it is not bronchopulmonary, only lymphadenopathy or pulmonary, no communication bronchus, so no sputum will be there. So all those reasons we might get the gastric lavage. Or if it's possible, older children or the mature child, you can get the sputum, but of course, might be very cautious whether you have collected the saliva or sputum. He should be very careful for that. And go for the X-ray test. Is sputum positive, then see whether it is if sensitive or not. Microbiology confirmed TB will say. If negative, but the X-ray suggestive tuberculosis, we will say clinically diagnosed TB. Sputum and all those negative can follow up and other treatment can be given. And when it is not tuberculosis are not going to give the anti-tubercular drugs, be careful for giving IPT. So and if extrapulmonary, again, he have to search the available resources, available tissues, available fluids. The CVNet culture positive, you have to go for the CVNet culture if you get the samples. So in case of FNAC, you can say lymph node, you can go for the FNAC, or sometimes a biopsy tissue material should be, don't keep it in a formalin. Don't keep it all the tissues in the formalin. You have to give normal saline, and in the CVNet machine there is a crusher tube. They will crush it and then keep it in a falcon tube, and then they put in a chamber, and you can get the result. If there is a biopsy, you can go for the histopathological examination. You can get the typical granuloma, and that may suggest as a tuberculosis. And of course, even if it is extrapulmonary, by clinical features you are suspecting extrapulmonary, always go for the X-ray chest and other radiological examination which is possible to help for your diagnosis, and then diagnose as a extrapulmonary TB. Then if result is come, then you have to see the result whether it's a reef sensitive or reef resistant. So MTB is not detected, okay. If MTB detected, then the reef sensitive, then you have to new TB patient and to treat. If previously treated not less than 1 month, then you have to initiate a TB patient history previous treatment for TB for more, and then you have to take the positive or possibly a resistance is there or not. But if the reef sensitive, you have to initiate reef sensitive regime of ATT, anti-tubercular drug. If MTB is not detected, if detected but if a patient is resistant, then what will you go? If you have done it in there's a Reef Ultra machine is there now, the recent machine where you have to do the once. If CBNet shows the positivity and the resistance, you don't have to repeat it. But in case of what we do, the CBNet machine where you have, if the reef resistance is there, you have to do the second reef resistance. New patient referred to TB, DRTB center, they again there was a reef resistance test will be done or CBNet will be done. If the second time it is CBNet positive, then we go for the DST, ideally drug sensitivity test to be done. For DST, drug sensitivity test and all the cases of DRTB, drug sensitivity test done by the LPA or the liquid culture. Then according to the drug sensitivity, the child should be given the treatment. So how will it start? Suppose a child is diagnosed simultaneously with the TB and the HIV. So first you have to start the TB, and after initiating TB, let the child stabilize the and tolerate the TB drugs in 2 weeks to 2 months time, and then start the ART. And but it's very important because the ATT and ART, that a simple young child is taking so much of pills and all, the chances of compliance may be very poor, and there be less adherence. So counseling should be very one of the important aspect of treatment. Counseling needs regarding pill burden because of the ART, ADT, pyridoxine, then the other might be getting vitamins, then the iron tablet and all those, or antibiotics and all those things. The huge pill burden is will be there. Drug interaction will be there because the lots of drugs are interacting with each other like a antitubercular drugs. We are giving them some enzyme inducers, some enzyme, the additive toxicity may be like hepatotoxicity in the antiviral drugs, and some ART drugs that will have hepatotoxicity that will give the additive toxicity in the results. So TB, as you said, there may be immune reconstitution inflammatory syndrome, TB iris. Again, TB iris may be unmasking type and maybe paradoxical type. What is unmasking and what is paradoxical? Paradoxical means the symptoms which are not there, it will be unmasking means if the symptoms are not there, then the symptoms will start. And paradoxical means suppose that the lymph node is there, 3 centimeter, you started giving ATD, you are thinking of it will be gradually, it will be slowed down, will decrease in size. Rather, it is increased and fluctuant and burst out on sinus. That is the paradoxical reaction. So there may be two type of reactions: unmasking reactions of iris and paradoxical reaction of the iris. Now, what drug you will give? Weight less than 20 kg, age below 6 years. So actually, I can't see the chat box. So okay, so less than 20 kg or age below 6 years, then what should be the regime? Whatever the normal regime we give, it is we give the abacavir, lamivudine and lopinavir. But as it is a TB co-infection, and you are going to give already maybe started ATD or you are going to start the ATD and all. So what you'll do in case normally abacavir, lamivudine twice daily as per weight band, lopinavir we used to give 4:1. But in case of tuberculosis infection, when you're going to add rifampicin based regime, then it should be 1:1. So you have to add separately ritonavir to make it equal percentage. Lopinavir and ritonavir ratio will be 1:1 twice daily as per weight. But if the child is more than 20 kg, above 6 years, but less than 30 kg and less than 10 years, so this is the age where you can start a dolutegravir. So the previously we are giving abacavir, lamivudine and lopinavir, ritonavir. Here we will give abacavir, lamivudine twice daily as in the previous case also, but instead of lopinavir, ritonavir, here we will add the dolutegravir. So, but the dolutegravir to be given 12 hours apart, because the TB patients don't have to be given twice daily. So twice daily, someday what happens, the one drug is taken at 8 o'clock and second drug might be taken at 6 or 4 p.m. No, it should be at least 12 hours apart. So when we write 12 twice daily, it must write in bracket 12 hours apart. So time is very important. Then the weight above 30 kg, above 10 years, then it mimics as a adult. So as we give in adults, meal treatment can be given in the children above 30 kg and above 10 years. So this will be tenofovir, lamivudine, dolutegravir. Tenofovir, lamivudine, and dolutegravir once daily with additional dose of dolutegravir 50 milligram after 12 hours. That's important. So you have to mention it after 12 hours. So and one thing is very important. You have to keep in mind that dolutegravir will need to remain twice daily for 2 weeks after the stopping of rifampicin containing antibiotic. That's very important. And when you are giving the super boosting, not only boosting, super boosting means 1:1 ratio ritonavir. That to be also continued for 2 weeks after the stopping rifampicin containing antibiotic. So any infant child initiated in any regime must be based on the body weight. And there may be constant change of body weight because if they start taking antitubercular drugs, ART, taking after counseling, they are very much conscious about the diet and all. They might gain weight rapidly. Then you have to change the drug. Sometimes what happens because of the sudden there is a superadded infection, diarrhea, and because of the rainy season and all that, then the summer season there may be sudden diarrhea and all, and maybe might lose weight. So it is very fluctuant. So you have to know the exact weight in every visit, and you have to check the doses schedule and the weight band also. Very important procedure. Now, who are already on ART at the time of TB diagnosis, ART modification needs to be done to maintain the optimal efficacy. So already ART, and now the child has developed tuberculosis, then you have to modify the drug. When ART present with the active disease, there's a possibility of failure. Whenever the patient is in ART and patient developed a tuberculosis or acquired the infection, what we think there may be the possibility of failure of treatment. But is it really so in all cases? That to be decided. So TB occurs in the when the after within the 6 months of initiation of ART, it is not a failure of the treatment because the ART has not worked properly. It will take time to suppress the viral load. So if in the within 6 months, we don't say it is a failure. Then ART should be adjusted with the rifampicin containing regime. In that portion, it should have been the I think INH containing regime. If TB develops more than 6 months of initiation, after the initial 6 months of initiation ART, and now we can think whether baby is having a treatment failure or not, because 6 months already given ART. So now decision of ART failure should be based on CD4 count, the level, whether CD4 also decreasing, viral load increasing, or it is not there. So pulmonary tuberculosis after 6 months of initiation of ART without other clinical, there's no other symptoms, no other features or immunological evidence like a CD4 is increasing the high, not decreased, viral load is not increased. So if there's no features of disease progression, then it is not a failure. It is a secondary tuberculosis infection co-infection because tuberculosis can happen in any stage. Extrapiramidal tuberculosis usually it is a failure, usually indicate a failure, but in case of simple lymph node TB or uncomplicated fluid disease can be there without failure also. That to be considered. The close monitoring is needed and adherence should be reinforced. So there are a few pictorial presentations. You see the severe malnutrition, only the whole body. I have given the many pictorial representations that won't take much time. Uh, Severe malnutrition, whole body, you see that only the skeleton and covered by the skin without any muscle mass and fatty tissue. So severe failure to type the only maybe the only presentation in child for tuberculosis. You see the axillary lymph nodes quite high, enlarged. So if you won't see, won't search, you won't get. And then you see the chest X-ray also. There's a highlight infiltration and the infiltration in the lungs. Cervical lymph nodes. It is seen in the posterior chain of the cervical lymph nodes enlarged, or sometimes a mediastinal lymph node. So even in X-ray also, it could be diagnosed that lymph nodes are enlarged. Now, when you see the primary TB, so in the X-ray, it's very important to look at the very cautiously. You see, there's a paratracheal lymph nodes and there's the hilar lymph nodes. So lymph nodes, no airway compression, so it is a primary tuberculosis. Second is the if you see the you see this is a hilar lymph node, paratracheal hilar lymph node, and there is a parenchymal changes over here. So this is a we usually say, and here also there's a consolidation. It may be primary complex. What is the primary complex? The primary focus, draining lymphangitis, and catchment area lymphadenitis. And if you carefully look, I don't know whether it is clearly visible or not. You see, this is the trachea coming down, and then this is the one bronchus. The right bronchus, it is there, and then the left bronchus. You see, there is a sudden kinking over here, and it is because of the airway compression. So if you see the lateral view, it will give a clear picture. There's a lymph node over here which is pressing the trachea. Bronchus, and there's a kinking. And of course, ultrasonography, you can see it. The lymph node disease with airway compression, and if there's airway compression, then beyond that there will be hyperinflation. You see the lungs are pushing so much down, narrow heart. So this is a progressive primary tuberculosis. And then you see a 14-year with the hyperinflation and the chest and the left hilar lymph node. Can you see my cursor? You see, it's a left hilar lymph node and alveolar consolidation is there. Here also there. And on the lateral view, this is the heart. You see, this is the heart, and above it, this is the hilar lymph node. Again, another picture. You see the right hilar lymph node, paratracheal lymph nodes, and alveolar disease, and right middle lower lobe is due to the tuberculosis. You see, this is again this is the heart, this part. Again, there is a consolidation, and you see this the sharp border. The sharp border are usually because of collapse. So this is a collapse consolidation with the lymphadenopathy. Now again, see the influence of miliary modeling. I'll show the other pictures of miliary modeling. The bilaterally small dot infiltrate all over the lung like a millets. So this is the one case scenario. I'll quickly go few cases. 4 months, 6 years, 4 months, 16 days old. You see the weight is 3.8 kg. So severe failure to thrive. 3.5 should have been at birth. So at 4 months, it is 3.8 kg. And fever on respiratory distress. Not improved with the antibiotics in by local doctor. And there's a history of contact the father. No improvement. That's persistent miliary remodeling. If you can appreciate in this X-ray, there is a miliary remodeling over very clearly seen over this part, and they are also both parents are detected HIV positive. At that time, they didn't know that they were positive. When baby came to us and we investigated and we found that both are positive. And you see, this is the, of course, the miliary modeling of not this patient. This is a miliary modeling X-ray of some other patient. My patient, we did the CT scan. You see the CT scan. So in the previous X-ray, it was not so much prominent about the miliary modeling, but you see the CT scan, whole lung is filled with the millets-like structure, and this is the miliary tuberculosis. The another case you see the diagnostic divide, the consideration, the bone. You see this is the bones focus. This is the draining lymphangitis. These are the lymphangitis, and there's a lymphangitis. Now we see this is a consolidation in between. There's a breakage and there's a cavity formation, and usually in the middle of, we say it is because of tuberculosis and because of hilar lymph node it's there here, and then there's a corresponding, there will be consolidation and there's a breakage and formation of cavity. Usually it is a tuberculosis origin. So radiologically also you can suspect whether baby is suffering with tuberculosis or not. Then again, in the cavity formations, I'm not going in detail. The consolidations, cavity with the consolidations, you can see different X-rays. So now it can be confirmed by ultrasonography or CT scan of chest. This is a parenchymal disease, so leading to progressive primary tuberculosis. And the case, 10 years old female child weighing 22 kg, just a fever for 8 days. They didn't bother for that anything, and just a fever for 8 days. That too also low grade, not too toxic. Came to my OPD and developed swelling on the left side. And CD4 was 484. Patient was on ALD, going quite good. And this swell is, they came with this swelling, the cystic swelling. So when I saw this patient, my resident sent it to for the pediatric surgery for operation cystic. Then they said a cystic swelling. But you see, it is clearly visible. There's no signs of inflammation, no redness. There was no tenderness also. Nothing was there. So it is a cold abscess. Then I did the X-ray. You see this X-ray totally clear and visible. It is a pleural effusion with a consolidation. So this is a cold abscess, and there's no need of surgery as you give the anti-tubercular dose as ATT is taking. So he baby is on a ALD. What modification will do? He will add one dolutegravir after 12 hours, 50 milligram along with this LD, and the anti-tubercular drugs to be started. Another case, 4 years, present fever, weight loss in 2 weeks, recurrent skin infection, otitis media. He is in stage 2, but there's an oral candidiasis, so he go into stage 3. 4 years means it should have been a 16 kg, and baby is 13 kg, so weight is quite low. 4 years, height is usually 100, a bit low, so it's not that much significant. Weight is quite low, and presence of all those features, cervical lymphadenopathy, candidiasis. Baby was investigated, and see a bilateral hilar lymphadenopathy and miliary modeling. Though the CD4 count is not that bad. So it is a tuberculosis pneumonia. You have to see the, as the child is 4 years, you might not get any sputum. You do have to do the gastric level and you diagnose it the whether the tuberculosis or not. But if it's not there, this type of a bilateral hilar, that is a mediastinal enlargement. This type of mediastinal enlargement is usually due to tuberculosis, if not due to malignancy. Of course, you go for the routine count and all, see any lymphoproliferative disorders are there or not. But usually it is in the tuberculosis and treat with the antidote. It's a known case of a TB patient initial first line ART, 2 weeks of surgery. 4 weeks of after initial ART, patient was present with fever, loss of appetite, and dyspnea. Identify the case for comparing the cases. So as soon as we started ART, HIV patient first line ART and anti-TB treatment, and after 4 weeks, he developed the fever, loss of appetite, and dyspnea like a pneumonia presentation, pneumonic complication. Because fever, loss of appetite, and dyspnea is the respiratory infection, thought of pneumonia. This was the X-ray prior to start to RT. After starting the antiretroviral, you see there's a pericardial cardiac cardiomegaly, there is a lung infiltration, there is a sub obliteration of the postphrenic angle. So this is the pericardial effusion with the pleural effusion, and it is the unmasking iris. So it is unmasking the features leading to iris. So in the case, Raja, 2 years, 9 months, initially asymptomatic, patient is only diagnosed HIV, father develops sputum positive, cough, fever, low grade, 3 weeks, body weight 9 kg, CD4 is low, anemia, 2 years, 8.8 means anemic. That may be due to HIV, maybe due to tuberculosis, MTB positive, recent. You see, this is a collapse and consolidation is there, and there is the lymph node also there. So how will you manage? So as this is the first case, you will start with anti-tubercular drugs, other antibiotics, symptomatic treatment. When the baby will stabilize with the anti-tubercular drugs, then you will start the ART. And 2 years, 9 months, what ART to begin? AL, LPBR, and the boosting, super boosting will be done with the ritonavir. I'll quickly go with others. Now, pleural tuberculosis. When to suspect them? Chest pain. Cough, breathlessness will be there, but there will be chest pain. And pleuritis. Chest pain is because of the pleuritis. As soon as there's a collection of fluid, chest pain will go. And then you will get the finding of the pleural effusion like dullness, decreased absent breath sound. So you have to go investigate with the X-ray. You have to collect the sputum and you have to drain the pleural fluid and go for the microbiological and nucleic acid amplification and biochemistry test. So if possible, diagnose, then okay. Otherwise, you can go for the CT. And of course, sometimes you might need the MTIT that the NTP people do. So pleural effusion result of hypersensitivity or some breakage, or sometimes it may be due to the disease progression. Another disease may be due to the pericardial disease, quite rare. We usually very rarely get in pediatric age group. It is a 0.5 to 4% tuberculosis cases. Make it to the obstruction or lymphatic drainage or invasion directly to the pericardium leading to pericardial effusion. The pediatric lymph node TB, this is very important. After pulmonary TB, lymph node TB is the common, and when to suspect? If there is an enlargement lymph node more than 2 weeks, so it's a persistent enlargement because recently onset of lymph node enlargement may be due to local infection, maybe due to allergic manifestation, maybe due to bite, maybe due to some allergic infections of contact dermatitis, all those things. So it's a persistent lymph node enlargement is there, and it is multiple sites. If it is matted, if there is a sinus, that is a C, or if there's other systemic signs, then it is a signs of maybe the tuberculosis. You have to investigate. So you have to go for the aspiration for NAT for smear and cytopathology. And if not possible, then if it is not result is not conclusive, then you go for the biopsy of the lymph. So chest says a lymph node more than 2 centimeter. See this matted is there or not. If matted or lymph node accessible, can go for the aspiration and NAT. Of course, if it's lymph node, as I already said, you must go for the X-ray also. In all cases, you look for the X-ray because sometimes you might get flu. And of course, if there's no abscess, no sinus, it's your confusion if there is tuberculosis or not, then give it antibiotic of the only plain cotrimoxazole or amoxicillin clavulanate acid for 10 days. And but you should avoid linezolid and quinolones, which can be used for a second line of tuberculosis. So it should be avoided. Review after 2 weeks whether the decrease is always mention the size. Don't give assumption. Always mention the size in a dimension in centimeters. So you will see whether the decrease or not. Excision core biopsy can be done. If there's no improvement, then CT culture is positive or not. But if this is less than, it is more than 2 centimeter. But if the more than 1 centimeter with systemic symptoms like weight loss, fever, and all, then it is significant and follow the same pathway. Now, this is next important is commonly missed, not important, rather is commonly missed tuberculosis. That is the abdominal tuberculosis. They might present with the chronic diarrhea, anorexia, weight loss, or sometimes the altered bowel weight. Sometimes come a constipation, sometimes diarrhea. So you must look for this. And if there's a red flag signs are the presence of red flag signs of abnormal pain, abdominal distension, altered bowel habits, constitutional symptoms, think of abdominal tuberculosis. And the abdominal tuberculosis are four types. One is the peritoneal involvement. One is the maybe the only nodal involvement, maybe intestinal involvement. Peritoneal involvement will be ascites. Nodal involvement, pain abdomen, lymphnodal asthma. Intestinal involvement, they present with the intestinal obstruction and altered bowel habit. But there may be other involvement, other organs inside the liver, inside the abdomen. So there may be liver involvement, pancreas, the granuloma in the liver and spleen. It is tuberculosis until proved otherwise. So if you see the CT scan and USG and they show that the granuloma in the liver or spleen, think of the tuberculosis. Then you just disprove. Don't have to prove it. You have to disprove it. Other. So it is until proved otherwise. So abdominal pain, fever, jaundice, other features might be there. So look for this. So abdominal TB should suspect when these symptoms are there. What are the red flags? Maybe the abdominal pain abdomen in the night time, chronic and severe nocturnal diarrhea, gastrointestinal blood loss, localized distension of mass, or sometimes ascites, features of cervical intestinal obstructions. So these are the investigations. You know, if the ascites is there, you go for the ascites train and investigation of ascites. Another, depending on the, you can go for the USG, you can go CT, you can go for the stool culture, you can go endoscopy, The alternative, look for the peripheral nodes, of course, on all the cases, always look for the nodes and the pulmonary features. So even in the abdominal tuberculosis, you're suspecting, you go for the pulmonary, such in the pulmonary tuberculosis. So X-ray must, USG, do chest X-ray, lymph nodes and other organs, ascites, all those things we have to do as a whole investigation to be done. Like in case of abdominal tuberculosis, sometimes you might need the CECT to rule out the idiopathic tuberculosis. So now some cases of bone tuberculosis. This is my patient again, 4-year-old child presented with the just swelling. They didn't bother the 4 months with the fever of 4 months, low grade. They don't bother for the fever now. And when there's a back swelling and the baby started bending, then they came to me. Mother had a history of pulmonary tuberculosis, and she took for 4 months, and she stopped as she is not getting adequate relief as she was expected, so stopped it. 4 years, severe weight loss, 11 kg, and see the hairs also red and all. That she was malnutrition there. 9, CD4 19%, and 2 was luckily for more than 8 millimeter, may not be, maybe negative because the bone tuberculosis might get. But what is your diagnosis? It is a diagnosis of post spine. You see, there's a gibbous formation. See, there's a destruction. Here again, the destructions are there. You see, there's a destruction showed paraspinal abscess here, and intervertebral discs are decreased. So this is a tuberculosis, nothing else. So to give the ART, this is a bone TB, you might have to give the for 9 months to 12 months. Now another case, recently I found this a 15 years old child presented with a monoarthritis, and it has been treated for oligoarticular GIA, then systemic GIA, and mistakenly baby, that child was given methotrexate, adalimumab, and corticosteroid. So whenever they are given the corticosteroid, there is a decrease the swelling, pain, and all. As soon as they stop it again, so for the last 1 year, they are having all those wrong treatment. Then they come to us, and we found this HIV positive, and the case is rifampicin resistant tuberculosis. Very surprisingly, because of the steroid and all those wrong treatment, it became resistance, and so it became a rifampicin resistant tuberculosis, and he was given the DRTB treatment. And this part was done the surgery, and still we are waiting for the patient to come for follow-up. Now, a few words in the CNS tuberculosis. It may be the most important. It can be meningitis, can be tuberculoma, can be involvement the spine. So, in case of meningitis, the most characteristic is the basal exudate. If the CT scan shows basal exudate, to take it granted, it is tuberculosis until proved otherwise. If unexplained hydrocephalus in a young child, presence of tuberculomas, these are the very typical signs of tuberculosis meningitis. And presence of infarction, of course, if the fever and other features of meningitis leading to infection, then you can suspect the TB. Otherwise, it may be other causes also. And in case of porcine, as I've been shown in the many cases, my patient at night. So this is a tuberculosis. This is the hydrocephalus. So consideration of the concomitant ART and ATD, we should be very careful about drug interactions. Rifampicin is a potent inducer, as I say. So we have to modify. You have to give the extra dose of dolutegravir, and in case of protease inhibitor, you have to give a boosting, super boosting of the ritonavir. Then in case hepatotoxicity, so we be very careful. You ask for examine the child for hepatotoxicity, whether there is a maybe ecteric, tender, or having enzymes are raised or not. If enzymes are more than 3 times raised, then you have to follow up the child. Close follow up to be done. In case incidents adverse effects, other adverse effects, drug, skin rashes and others, possible development of iris, as I've shown the picture of iris, and of course the high pill count should be considered and it should be counseled, may affect the patient's acceptance. So this is my last slide of key points of my presentation. All children with HIV have to be screened for TB in all visits of the ART center. Post-symptom screening to be done as an intensified case finding protocol. You have to search any source and every visit. Not only these 4 symptoms, with the glands and abdomen, diarrhea, constipation, abdominal distress, all. CBNAT is a preferred investigation tool for detecting TB. Daily treatment in children from the dot providers. Fixed dose combination of ATD is given. FDs is there. Appropriate ARB to be given, antiretroviral therapy to be given as a NACO guideline after 2 weeks, within 2 months of the ATD initiations. So these are the guidelines I have followed. National Guideline 2021, Indian Academy of Pediatrics, National Tuberculosis Television. And the most important part, I have given the website tbcindia.nic.in. Can go and you can get all the things, whatever you want to know about the tuberculosis in our country. Thank you for patience. If any queries, I'd love to answer. Thank you.
Thank you so much,
Over to
ma'am.
Shiva.
Yeah, thank you so much, ma'am. There's one question in the chat box, ma'am. Is there any role of LAMP test?
Yes, there's a role on ampicillin clinically diagnosed, but it is not in the guideline, not in practice, and it's not available in India also. But it is done in the adult. There's no study done in the pediatric, as I said. But LAMP test can be one of the mode because the non-invasive method, very easy to collection the urine and all. So there is a role, but still to be more studies, meta-analysis to be done before it can come in the guidelines.
Good afternoon, madam.
Yes. Good afternoon.
I am SMO Dr. Tripathi from Bhubaneswar ART Center. Madam, my question is, can we give Zidovin based ART below 20 kg and 20 kg to 30 kg children?
I can give you sometimes abacavir sensitivity, hypersensitivity, have toxicity is there and all, or failure in the abacavir. We do give the Zidovin. It's not a contraindication, but before giving Zidovin, you have to rule out there's anemia is there in less than 9 gram percent. And of course, if it's less than 9 gram percent, then the anemia is because of the nutritional origin or something else. You have to rule out. If it is then after increasing the hemoglobin level, you can give it. No issue.
Madam, my next question is, what duration of exposure is regarded as contact positive?
As I said, because I searched, there's no definite definition of duration, but I got it in if you go in that guideline in the NTP, as I said, tbic.india and nic.in, it is written there's an overnight exposure. Overnight exposure means overnight means at least 8 to 10 hours, as I understood, because it is written overnight exposure with the contact positive in a closed house for more than 1 day. So 2 days at least overnight exposure when is staying together and spending the whole day 24 hours, then it is a contact positive in a closed house.
कोई मैक्सिमम कोई ड्यूरेशन ऐसा है जिसको मतलब कांटेक्ट
मैं जो बोल रही हूँ ना आपको जो मैंने जो डेफिनेशन बोला वो टीबी एलिमिनेशन प्रोग्राम जो गवर्नमेंट ऑफ इंडिया है उनका डेफिनेशन है. इफ यू गो द एआरआई कंट्रोल प्रोग्राम एंड ऑल, उसमें लिखा होगा आपको. आप ये TBIC मैंने जो वेबसाइट आपको दिया उसमें लास्ट में मेरा था .nic.in. If you go, there is a contact history and there is lots of FAQs are also there. You can ask questions, you can get your answers many times. But the contact is definitions given in the Contact is for the more than one overnight stay in a close space with the person who are having tuberculosis. Actually, in definition, an older patient and all, it is open type of tuberculosis. But in pediatric patients, we do take any type of tuberculosis. Because someone asked me, ma'am, if there's a tuberculoma, how come it will be contact positive? But in case of tuberculoma, we might get some tuberculosis in the lungs, but in the normal X-ray may not be visible sometimes. The finding is hidden inside the back side, on the lateral side, or behind the trachea. Sometimes not visible. So we are not going to do CT scan in each and every cases. So it is by virtue of its taking benefit. So we take all type of tuberculosis in adult is contact positive in case of pediatrics.
Hello.
Okay, thank you, madam.
This is the definition by
Hello.
Indian Academy of Pediatrics.
Hello, ma'am.
Yes.
Ma'am, what is the effectiveness of the Monto test in the children?
Okay. Uh, 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 what is your question? Acuteness? I couldn't get it. Monto test, I got it.
Effectiveness of
Oh,
how
effectiveness.
reliable.
Yes. Okay. We do Monto test sometimes because we know like tuberculosis in lymph node tuberculosis, 70% positivity. But in pulmonary tubule may not be positive also. It is a hypersensitive test. So this is a hypersensitive due to tuberculous protein, and that is manifested as a wheal and erythema. That is Mantoux test. Clear. So what
Is it
happens in the HIV virus? There is all immunosuppressants there. So there may not be any hypersensitivity reaction. That's why we say the Mantoux will be negative in HIV patients because immunosuppression, they won't allow the immunity to react against the tuberculous protein. So might not get a hypersensitivity. But if you get, this is positive, definitely positive, definitely positive.
you
But
mean to say it is a reliable in children if it is
yeah,
not
it is
negative?
there. It is there. But it does not rule out. If it is positive, it does not say that it is a tuberculosis disease. Positive means
Right.
there is a exposure to the tuberculosis because there are three stages in tuberculosis. First, there is exposure. Second is the infection. Third is the disease. Okay. So exposure means all of us, all the doctors, all the healthcare, we have been exposed to tuberculosis bacilli. क्योंकि कितना टीबी हमने देखा है ना, तो we all exposed, but that does not mean we are having infection, that does not mean we are having disease. तो किस सबका
No.
जिसका जिसका एक्सपोजर हुआ उसमें कुछ परसेंटेज का इन्फेक्शन होगा, infection hoga,
Okay.
that is the latent tuberculosis bacilli. That is we say LTBI, latent tuberculosis bacilli infection. That means we are
Right.
not clinically manifesting, but we are having.
Okay. Okay, ma'am.
So,
That's very true. Now we have the term IGRA,
नहीं
which has
IGRA
come in.
LTBI का नाम नहीं है. IGRA is another test, interferon gamma release assay. IGRA है ना,
Yeah,
वो क्या होता है ना, tuberculosis bacilli is sensitize the lymphocytes. वो sensitize करके
exactly.
lymphocytes से lymphocyte secrete करते हैं, that is gamma interferon, और उसको गामा से हम लोग गामा रिलीज एसे से हम लोग डिटेक्ट करते हैं. सो इट इज कॉल्ड IGRA, interferon gamma release assay, and that is secreted
So
by the
that I mean, my question is, where do we use IGRA test?
okay, this is also for the LTBI. It is
Okay.
not to diagnose the disease, because in the western countries they are doing IGRA and all because they are treating LTBI, but we are not treating LTBI. LTBI means latent tuberculosis bacilli infection who are not having symptoms. उसको हम लोग लेटेंट LTBI कहते हैं, एंड जब हम लोग का सिम्टम्स होता है वो लोग उसको हम लोग डिजीज कहते हैं. वी आर टेलिंग दैट देयर डिजीज. सो एक्सपोजर इन्फेक्शन डिजीज. तो LTBI के हम लोग इंडिया में भी ट्रीट नहीं कर रहे हैं, नहीं तो हम लोग का 90% को ट्रीट करना पड़ेगा एंड वी विल फेल दैट प्रोग्राम. बट इन
So you
HIV,
mean is it true that IGRA is meant for contact tracing?
yes, contact tracing you can do the LTBI, you can do it IGRA कि उसको जैसे in non-HIV patient we do it always not IGRA because it's not available, or we do the Mantoux so that we can get the prophylaxis. But here we are giving prophylaxis even without any history of contact in all cases of HIV. No, we are giving INH prophylaxis. No, so there's no point in doing all those things. But in HIV negative we are doing like when you are going to start nephrotic steroid, when you are going to start the monoclonal antibodies, when you are going to start chemotherapies, what we do the Mantoux, if positive, give the INH prophylaxis and start the treatment. What do we do? But that is to know whether the baby has been exposed and having infections or not. But here we don't do in HIV. We always give a prophylaxis in all cases. If manifest is if disease, treat it. Got my point? Are you clear?
Dr. Lara, sir, sorry, you'll have to unmute.
Me?
No, sir will have to unmute.
I'm unmuted.
Yeah. Ma'am, I'll just continue. There's one more question in the chat box. As we are giving ethambutol for
For a long
prolonged
time.
time, now under ATD, what is the risk of loss of field or acuity of vision or color
And color vision.
blindness?
Yeah. Actually, previously said there is a loss of vision, color vision, acuity vision, and pediatric age group, they cannot complain, cannot say this. But study has been shown this is not so much. We have at least me and one that too also older age group. We don't get so much the side effects in pediatric age group. So we are not getting. And actually we don't have exact data also. So, but practically, by experience, and we are not getting so much side effects than ethambutol as it is said due to ethambutol toxicity. But it is screening to be done. Person who are giving ethambutol, all even the children who are giving ethambutol, the regular screening to be done for this because they cannot complain. I can't see this color, can't differentiate this color or not. Color visions and acuity visions.
Thank you, ma'am. Any more questions from the participants? Please feel free to unmute your mic and ask your question. You can also type the question in the chat box.
I just want to know about the INH prophylaxis in the children. I mean,
Yes.
how, yeah.
Okay. So an INH prophylaxis is as same as an adult in all the cases except below 12 months. Okay. Above 12 months, whoever having the tuberculosis, you treat it, and after that start IPT. Or who is not having tuberculosis, give IPT, provided that there's no contraindication, as I said already. Okay. But below 12 months, 12
No,
months means
that's very true. But we have the guidelines that iris do develop between 6 weeks to 6 months. So should we start?
yes, 6 weeks to months. It's only says 3 to 6 months. Hmm.
Exactly. So how should we determine that he or she is free from, I mean, forest and all? I mean, to say that what is exactly the time to start the IPT? I mean, after 1 month or 2 months or 3 months? Because
Better to
as per the previous guideline, it was before
3 months.
after 3 months.
Yeah. So usually it is 3 months so that okay, we can treat and all because our motto is to prevent the further disease. It can prevent if you give the IPT, it can prevent 60 to 90%, as I've shown by the slide. That it can prevent it. So if there is a exposure, it can prevent to become a disease. What happens and the manifestations because when you are giving ART, that means there's a immune recovery is going on. So if then when there's an immune recovery, then the TB can react, then can present. So this is a chance of having iris. But after 3 months, you go on waiting and waiting is no point in doing this. So you have to start iris.
You mean to say as early as possible?
No, we don't do as early, but it is really better to start after 3 months. We can start that. But always and every month you have to check whether baby is developing any disease and any symptoms or they improving or not. Because in children the response is either rapid or deteriorate. So if you start ART, and that one case I have shown in the 4 months to 20 days old, I think that patient had a 3.8 kg. And after starting ART and nutritional therapy and admitted in my ward and quite goes a 6 kg and all, and now he is quite okay. So there's a if you take care of very beginning with the proper treatment, we know near normal, you know. So you have
Ma'am, do we really encounter with the paradoxical iris?
yes, sometimes not that common as in adult.
Okay.
Because usually what happens when there's a TB, they usually manifest before start. They will have a many some features of tuberculosis, and you suspect you treat. Rather, you don't treat and give ART and wait for the paradox. That the scenario is less in pediatric. You got my point?
Right, ma'am. Thank you so much. Thank you.
Thanks.
Uh,
Any discussion about the poll questions?
Ma'am, I'll just go with it. Right now, there's one comment from COE STM. In other words, should we postpone IPT in children where we suspect any lung infection which is yet to be properly diagnosed?
Yeah, actually, how many times you'll take? So if there is a thinking of acute infection, it may be acute pneumonia or the persistent pneumonia sort of. Acute may give antibiotic for 2 weeks. You say that the guidelines are 2 weeks. Then you go for suspecting. Okay, whether improved in the radiologically improvement is there or microbiological improvement is there or not. If because microbiologically diagnosis nowadays quite possible because of biofire and all, but it is not available in all the centers, of course. In the COE centers it is available. So if you clinically give it and think of it this case, so pneumonia is treat with the antibiotics. After 2 weeks, if the persistent lesion, that may be tuberculosis, so we have to treat. But if there's no signs and all, then you have to wait because go on waiting for suspicion for long period, it doesn't happen in pediatrics.
Ma'am, we'll quickly run through the post test first. Kiran sir, can we have the post test, please?
I can see.
Yeah, yes. Yeah, ma'am.
Question number, which of the following statement is not correct?
Okay.
TPT should
Right.
not be given in patient on more than 12 months who is not having active TB, which is not correct. When it is wrong, should be given. Of course, first person is right. HIV exposed infants less than 12 months. Of course, as someone was asking, was INH in less than 12, INH therapy less than 12 months. In less than 12 months, you have to have a history of contact, then only give the INH. In case of HIV, in other, if you see the first question, all the children who are having more than 12 months and adult, we put on IPT if it is maybe that the person is not having tuberculosis. But less than 12 months, only if this is the line, contact with the active TB. Means we have to have a history of active TB contact. Then only you can give the INH. Otherwise, you don't give the INH below 1. So this is also TPT reduces the overall risk of 60% and 90% among the patient. Again, this is also correct. TPT should not be given to the pregnant woman. TPT means iron is not contraindicated in the pregnant. So this is wrong. It should be given. TPT should be given to all individuals with previous injury. Yes, in the HIV it should be given. Okay. Second question. This is third. Breastfeeding can be given. Breastfeeding can be given to all except DRT. It's very important. Except in drug resistant TB, you can give the breastfeeding. Of course, this answer is it will be express breastfeeding. We cannot give directly from the put on the breast because we don't have a prophylaxis for DRTB. So you just separate the baby and can give the express breast milk because tuberculosis bacilli transmitting through breast milk is not happening. So we can give the breast milk by expressing it, but not by sucking breast. ATT excreted small amount, yes, but that does not cause any benefit or harm. All children born to mothers TB should receive BCG. So in India, BCG is not having the INH resistant. We don't have INH resistant BCG. Western can they have INH resistant BCG. So if you put on INH profiles and give BCG, but here also, even though we don't have INH resistant BCG, simple BCG, what we give in other children must be given to all children along with INH. So this is what. Third one. Yes, current cough everyone knows, fever, poor appetite. Actually, poor appetite, now it should be history of contact positive. So this is fourth one. TB occurs in less than 6 months of initial ART is not a failure. Yeah, first 6 months, that means ART has not started working. You have to give the time for ART to work at least for 6 months, so you don't see it as failure. The ART should be adjusted to the reformation containing. It should be INH containing actually. Wrong. I said that the option was which is correct. This is also correct actually. If TB develops more than 6 months of initiation of ART, then decision of ART failure should be, yes, be based on the CD4 count and viral load. This will guide you whether the disease is progressing or not, but not guide you about the TB disease. So this is correct. PTB after 6 months of ART without other clinical immunological evidence of disease progression should be regarded as an ART. No. It should not be regarded as ART failure because immunological and virological parameters are okay. Thank you.
Thank you so much, ma'am. I'll just take any last questions from the participants. Thank you so much, ma'am, for the detailed, informative session. Thank you to all the participants for patient listening. Ma'am, can we conclude the session now?
Yes, thank you.
Thank you, ma'am.